My name is Dr Alikhani. I am Dean and Professor at CTOR Academy, and I'd like to welcome you to another session of CTOR Chat. Today we continue our discussion on sequencing. Regardless of your patient's problem, you can have 3 stages of mechanotherapy ahead of you. The first stage is called biomodifier free object design. Your patient may not need that, but if the patient has a complex problem, usually we start from that. The second stage that is more common among all the patients is a semi-restricted design stage, and the last stage that all patients will receive is retention. Let's start from biomodifier free object design stage of mechanotherapy. Any patients that is coming to your clinic for consult may need immediate attention. These are the patients that have traumatic occlusion, impinging bite, habits, pain and discomfort of the TMJ, and many of these problems that immediately need your attention. We cannot wait until we do the proper mechanotherapy and take the patients to the final stage. You need to do something now. These patients start with biomodifiers. So regardless of their mechanotherapy problems, pay attention. If the patients require immediate attention, you need to give them biomodifiers like an anterior bite plate, posterior bite plate, space maintainers, many habit appliances. Many of these appliances that can help to immediately stop or control the patients to apply more harm to themselves. After this stage, after this immediate need has been paid attention to, now we start our design of our mechanotherapy. Always remember, you start from the major problems and major movements toward minor problems and minor movements. Why? You don't need to expose the teeth that has minor problems to braces or aligners too early while you are focusing on the major problems to be addressed. Avoid minor movements or minor targets when you're having a major targets that need to be addressed. And most of the time, the time-consuming problems are the major targets anyway. And not having the appliances on minor treatment is actually cosmetically can help the patients for a long time because they are not exposed unnecessarily to appliances. So from the major target point of view, we have dental arch or a segment. You are starting with a dental arch. Does your patient has any dental arch problems that you need to address separately as a major movements? These problems can be divided to transverse problem, sagittal problem, and vertical problem. Always remember, if you have a dental arch problem, you start with the transverse problem first. Address those problems before you're addressing the sagittal and vertical problem. Why? The transverse problem usually cause change in sagittal and vertical problem automatically. You may not need to engage in sagittal and vertical correction extensively if you first address the transverse problem. So start with them. In addition, transverse problem always come with the benefit of making a space for the dentition. Majority of our patients, regardless of dental arch problems they have, they are suffering from lack of space. So transverse correction have that benefit automatically. The second part, you start with the sagittal correction. Pay attention, sometimes it is possible to combine sagittal and transverse at the same time as a synergistic mechanic. For example, maxillary advancement in the class 3 patient can be combined with the transverse correction. We are stimulating the biology of the suture, we are activating the osteoclast in the suture to allow the more movement of the maxilla transversely. At the same time, we can use these sutures that are going through the remodeling and moving the maxillary forward. We will talk about this one forward. I just want to emphasize, sometimes it is possible to combine them. Sometimes it is not possible. You need to first do the maxillary expansion, then do the mandibular advancement if the amount of the crossbite is so significant that does not allow the mandibular advancement at all. So if you can combine. If not, sagittal need to be done after transverse. Vertical problems of the dental arch should be done the last. The reason is that most of the time by correcting the sagittal, automatically your vertical problems start to get a different color. For example, a patient comes with a severe class 2 deep bite, and it seems that you need to intrude the anterior segments. But if you do the mandibular advancement, you actually notice that you need to do the posterior extrusion, and there is no need for the intrusion of the anterior segments. So sagittal correction can affect your vertical correction significantly. Pay attention to the vertical correction of dental arch at the end. But that doesn't mean that you should not control your vertical position while you are addressing transverse and sagittal position of the dental arch. Don't let those vertical problems become worse. You don't need to treat them right away, but prevent them from becoming worse. Application of posterior bite plate, application of anterior bite plate, and many of these designs can help to control the vertical while you are addressing a transverse and sagittal problem, so they don't get out of control. Vertical problems of dental arch usually addressed through a segmental mechanics. Because most of them, they are exposed on a segment, so they are not really a dental arch problem anymore. The posterior segments need to be intruded or extruded. Anterior segment need to be intruded or extruded. That can be addressed with a simple segmental mechanics. One couple system, two couple system, for example, intrusion of extrusion arch, application of the tab, and free object design through that segments, they can address the vertical problem of the segment simply. That also usually be done before we started to have a semi-restricted design with all the appliances inside the mouth. While you are doing the correction of the dental arch and segmental arch, remember, if there is a major dental movement that can be helped in this stage synergistically, please add it to your design. You don't need to wait for the semi-restricted design to address those problems. Most of the time you cannot, but if you can, add it. For example, you're designing an expander, you can design an additional spring to the expander. That expander works as a very good anchorage and vertically erupt a impacted tooth while you still have the expander inside the mouth. You can add a distalizing arms to expander and distalize the second molar that you plan to achieve later on in semi-restricted design. You can achieve it now while the expander inside the mouth. So these simple major movement, even though they are not the target of the free object design stage of mechanotherapy, but they can add significantly in saving time and efficiency of your mechanics. Next time I'm talking about the semi-restricted design. I hope you enjoyed this session of CTOR channel. If you have not subscribed to our channel, please go ahead and subscribe, and please don't forget to press the like button.